Assalamualaikum and hi future pharmacists. Hopefully all of you in good shape. Previous week, we did cover the pharmacological treatment for diabetes mellitus in terms of the drug pharmacokinetics, mechanism of actions, side effects, and any precaution measure to take to make sure the glycemic target within the range. So today, we will cover the anti-diabetic drug management to treat the diabetes. To ensure that you guys are able to grab all the crucial points in this lecture, I want all of you to put yourself in the position as a future pharmacist. Let's begin. We will split to the lectures into two parts. The first part, we will cover the glycaemic monitoring and way of control the blood sugar in terms of pharmacotherapy, besides the algorithm for lowering glucose agents in type 1 and type 2 diabetes. And the second part, we will cover the pathophysiology, clinical features, and treatment for acute complication of diabetes mellitus and how to manage the glucose lowering agents for diabetic patients who are fasting. As we discussed last week, diabetes can lead to complications in many parts of the body, such as stroke, blindness, heart attack, kidney failure, and the most common you can see for uncontrolled diabetes are amputations. About 422 million adults have diabetes and around 5.2 million deaths due to diabetes. It is because diabetes increases the risk of medium and large arterial wall damage and subsequent atherosclerosis, which can lead to heart attack and stroke. Major contributors to mortality and morbidity. Let me see how our country Malaysia dealing with this issue. This is the summary report on 2015 by National Health Morbidity Survey. As you can see here, 1.8 million in past 5 years ago do not aware that they have diabetes or kencing manis. Do you guys can imagine how about today in 2020? Kedah followed by Perlis and Johor are among highest states that have diabetes. In terms of race, Indians are the highest.
Tarik kau, kopi kau, let's go kau.
That is one of the many factors contributing numbers of diabetic patients in our country. Everything is cow. For your information, we are the 8th highest sugar user in the world. We are standing in the eyes of the world, guys. And most of the diabetic patients are overweight or obese. Let's see where we stand in our Southeast Asia region. Yeah, we are the highest overweight population in Southeast Asia. See the picture here? The boys are too cute to be handled. He is so happy to have donuts with him. So, where are our role as a pharmacist here? What should we do to help our own citizens in terms of our profession as a pharmacist? As a pharmacist, we need to educate and encourage diabetic patients to do the self-monitoring blood glucose, which will improve their awareness and sense of responsibility for them to take care of their own health. Regular blood glucose monitoring is important for diabetic to avoid any emergency situations such as DKA, diabetic ketoacidosis, HHS, and hypoglycemia. The results also reflects the effectiveness of the drug, medical nutrition, and lifestyle therapy to prevent them from any microvascular and macrovascular complication in the future. Some of you not really understood the differences between the macro and microvascular complications. Both are chronic complications that can happen if the blood glucose level uncontrollable. The macrovascular, as you can see the word is macro, means large or big, which refer to any large size of the blood vessel including your coronary arteries, the aorta, and the sizable arteries in the brain and in the limbs. Meanwhile, for microvascular, refer to any small size of the blood vessels such as in the eyes and kidneys. HbA1c tests should be performed every 3 to 6 months. 3 monthly for the patient who fail to achieve their target. 6 monthly if A1C target is achieved and stable. A1C has strong predictive value, which reduction in A1C will result in a reduction in risk of microvascular complication in the immediate short term and macrovascular complication in the long term. However, A1C has their own limitation, especially in anemic patients, which their red blood cell turnover is high. In addition, A1C also did not capture any hypoglycemia. Because of that, the patients are required to do their own routine blood sugar checkup. Total of 7 points self-monitoring blood glucose, which is pre-breakfast, post 2-hour breakfast, pre-lunch, post 2-hour lunch, pre-dinner, post 2-hour dinner, and pre-bed. The patient do not need to take all the 7 points of self-monitoring blood glucose. The numbers are depend on what kind of treatment regime the patient receive. Pre-meal tests are a good way of seeing whether you have injected the right size of the dose for your previous meal. Let's say, if you do the SMPG on pre-lunch, the result is high, which is might be more than 8. It shows that whether you injected too little insulin or too much carbohydrate intake on your breakfast. A postprandial or after meal blood sugar shows how fast the pancreas reacts to release insulin into your bloodstream following a meal, and it also indicates how the drug works. Type 1 diabetes and latent autoimmune diabetes of adulthood, or also known as LADA, is an autoimmune disease, meaning our own immune system attack and destroy the beta cell in the pancreas that produce the insulin. That is why the primary treatment for type 1 diabetes and LADA is insulin. Insulin can be in the injected form such as in the syringe, pen, or pump. The HbA1c target for these patients must less than 7.5%, and they need to do the self-monitoring blood glucose level, which is individualized. This patient can be manifested by low or undetectable plasma concentration of C-peptides. C-peptide is a byproduct created when insulin is produced. C-peptide level is lower than 0.8, it means that your body doesn't produce enough insulin. Besides that, markers of the immune-mediated beta cell destruction process can be detected, which include the glutamic acid decarboxylase, or GAD5, insulin autoantibodies, IAA, anti-islet antibody, ICA, and zinc transporter A. The presence of these autoantibodies shows the beta cell destruction by the autoimmune disease. Patients with type 1 diabetes and LADA can present acutely with severe symptoms of hypoglycemia and frequently with ketoacidosis. That is why blood glucose monitoring is crucial for them to detect any symptom of hypoglycemia and hyperglycemia, as urgent treatment is needed. Actually, type 1 diabetes is a chronic disease of childhood, and it potentially affects the growth onset of puberty and pubertal development of the patients. The aim of insulin therapy is to mimic physiological insulin replacement as close as possible in all age groups in type 1 diabetes and LADA. There are two types of insulin therapy in type 1 diabetes and LADA, which are conventional therapy and intensive insulin therapy. Conventional therapy is defined as 2 to 3 injections per day, while intensive regimens as 4 or more injections in a day. For conventional therapy who receive 2 injections per day, 1 injection will be shot before the breakfast, which is combination of the rapid or short-acting with intermediate-acting insulin, and another one shot before the dinner. The only difference between 3 injections with 2 injections daily is they change The time taken for intermediate acting insulin that take before dinner, they change to the bedtime. The intensive insulin therapy can be known as basal bolus regimen and insulin pump therapy. In basal bolus regimen, or also known as multiple daily injections, consist of bolus insulin, also known as intermediate or long-acting insulin, that be taken once at bedtime or twice daily. And bolus refer to prandial insulin, which are the rapid and short-acting insulin that be given before each meals and snack times. Let's have a look. What is the insulin pump therapy? The choice of insulin regimen will depend on many factors as follows: age of patient, duration of diabetes, target of metabolic control, the lifestyle of the patients, which including the dietary patterns, exercise schedules, and the preference of the patient or caregiver. Intensive insulin therapy are more preferred than conventional therapy due to the slowing progression of long-term diabetic complications. Besides that, pre-mixed insulin is not recommended for type 1 diabetes because of its fixed ratio of insulin components and do not allow flexibility of dosing. This is the prandial insulin, or also known as bolus insulin. Short-acting insulin show better fasting blood glucose and HbA1c compared with rapid-acting insulin such as aspart, lispro, and glulicin. Short-acting insulin, also known as regular insulin. This is the basal insulin. Glargine is safe, non-inferior, and more efficacious compared to the intermediate-acting insulin. Detemir is equally efficacious in reducing HbA1c compared with the intermediate-acting insulin. Insulin pump therapy is still considered rare in Malaysia because of the device price quite expensive and unaffordable. Patients are required to purchase themselves to get it, and it is not available in the government hospital. This is how it works as shown in the videos previously. Multiple daily injections, or also known as the basal bolus regimen, the patients are need to calculate the food intake and adjust the insulin doses. If not, patients are reinforced to eating the right quantities of the right food and at regular time. The best thing of the insulin pump, beside the device and their mechanism of deliver the insulin pump can achieve more A1C reductions compared to the MDI. The daily insulin dose are lesser than the MDI. In government hospital, pharmacists play an important role in the DMTAG. DMTAG refer to the Diabetes Mellitus Medical Adherence Clinic. If a clinic required newly diagnosed and uncontrolled type 2 diabetes to enroll this program or module, what do we do? Besides educate them on adherence to the pharmacological treatment and encourage them to monitor their plasma glucose level, we also need to educate them to fully optimize the good lifestyle practice which focus on the nutritional plan, physical activity, sleeping pattern, and encourage them to stop smoking and from consuming alcohol. We should emphasize these patients to losing their weight, especially obese diabetic patients. Here are the all 8 group of anti-diabetic classes and their set of actions that we did cover on last week. Here are the summary of the side effects, contraindications, and benefit for all the glucose-lowering agents, including the insulins. As we recap back, sulfonylureas, meglitinides, and insulin may cause hypoglycemia and weight gain. Metformin, GLP-1RA, or also known as GLP-1 receptor agonist, as well as SGLT2 inhibitor may give advantage to the overweight and obese diabetic patient to lose weight and also reduce the risk from developing any cardiovascular events in the future. Unfortunately, this group of drugs are contraindicated to the renal impairment patients. Besides that, metformin can cause vitamin B12 deficiency, which is a causal factor in the development of anemia and peripheral neuropathy. Patient may feel kebas-kebas tangan and so on. So, supplemental B12 should be given to the affected patients. Here are the algorithms to decide which drug should be prescribed to the patients. In general, all the newly diagnosed type 2 diabetic patients are required to modify their lifestyle habits by increasing the physical activity and take care of their own daily nutrition intake. The drugs are decided based on the HbA1c and fasting plasma glucose level. Current practice is prescribing the metformin as the first-line agent as compared to early 90s, which is sulfonylureas such as glycaemic is the first-line agent. For high-risk patients which has comorbidities such as hyperlipidemia or high cholesterol level, as well as hypertension that achieve and manage the HbA1c and FBG value, we will encourage them to practice good lifestyle approach and monitor their postprandial blood glucose level. If the level more than 11 millimole per liter, we may introduce any one of the 5 groups of anti-diabetic agent. As usual, metformin will be considered the first choice of treatments unless contraindicated. Dual therapy may be given if newly diagnosed patient has HbA1c in the range of 7.5 to 8.5 or fasting plasma glucose level in the range of 8 to 10 millimole per liter. The dual therapy also may be given if the monotherapy failed to achieve their HbA1c target, despite the drug achieved their optimal doses. Let's look up how to optimize the anti-diabetic dose. This is all the glucose-lowering agent that available in Malaysia. As you can see here, metformin, it is available in the strength of 500 mg tablet. Initially, we will prescribe newly diagnosed type 2 diabetes with 500 mg once daily, which is 1 tablet before the breakfast. And the dose will be titrated up to 1000 mg OD, which refer to 2 tablets of metformin in early morning, or 1500 mg once daily, if the HbA1c target do not achieve their target. The maximum dose of metformin is 3000 mg daily, which you can calculate by 1000 mg times 3. We will counsel the patients to take 2 tablets metformin 3 times daily before each meal. Another group of class I want to highlight here are sulfonylureas. The available strength of glycoside or diamicron is 80 mg. The minimum dose is 40 mg in every morning, means that the patients are required to cut the 80 mg tablet to half. Usually, we will advise him to use the specific cutter that available in the retail pharmacies and take half of tablet in every morning. Similar cases for the patient being prescribed with 120 mg glycazide. We will counsel the patient to take 1.5 tablet in every morning. How about insulin therapy? Insulin therapy for type 2 diabetes may introduce in newly diagnosed patients who HbA1c more than 10% or fasting plasma glucose more than 30 millimole per liter. For type 2 diabetics, they will take the insulin together with the oral antidiabetics such as metformin, DPP-4 inhibitor or SGLT2 inhibitors. Metformin should be continued while on insulin therapy unless the metformin is contraindicated or intolerant. Sulfonylureas and meglitinide should be withdrawn while the primary insulin is used regularly with meals. Insulin dose should be optimized prior to switching or intensifying the regimens. As you can see here, if the patient has normal fasting and high daytime BG, which means that the pre-breakfast level within the range about 4 to 8 millimole per liter, but the plasma glucose level on lunch and dinner are higher. The doctor may introduce the rapid or short-acting insulin in each of meals. If the patient has high glucose level on early morning before breakfast, but the glucose level in the lunch and dinner are within the range, basal insulin, which is intermediate acting and long acting insulin, may be prescribed at bedtime or 1 shot of premixed insulin before the dinner. The basal intermediate acting insulin should be administered not earlier than 10 p.m. because the risk of nocturnal hypoglycemia. As we discussed earlier, total 7 points in self-monitoring blood glucose level. For patients that receive basal insulin only, they should monitor the fasting plasma glucose level. For patients ongoing intensive regimen or also known as basal bolus insulin therapy, the total of 4 points are required based on the type of bolus insulin as stated here. Let's redo some case study. As a pharmacist, SOAP note, or an acronym for Subjective Objective Assessment and Plan, is one of the systematic approach of documentation beside DPCI or pharmaceutical care issue. This method systematically identifies all the patients related to drug problems, complaints, and identify the optional or alternative treatment to solve it. It requires us, as a pharmacist, to work in concert with the patients and the doctors, as well as other healthcare providers to promote health, to prevent disease, and to assess, monitor, initiate, and modify medication used to assure that drug therapy regimens are safe and effective. S stands for subjective, which is the information that is provided by the patient and obtained in an interview. It consists of the chest complaint, history of present illness, past medical history, social history, and family history. O, the objective, is information obtained by the clinicians and need networks and diagnostic. It includes the medication list, vital signs, physical examinations, laboratory values, or diagnostics. A stands for assessment. It assimilates all these informations obtained from the subjective and objective areas and apply it to standard practice as defined by evidence-based medicines. It prioritizes problem lists and drug-related problems and do assessment and therapy justification for each problem. And the last one, P, is plan the final treatment plan is given for each of the active problems as specified in the assessment. Treatment plan, education and counseling, as well as monitoring, follow-up, and referrals. Let's look at this case study. It's a Madam J.A., 58 years old, housewife. Duration of diabetes is less than 1 year. No family history. So, no family history can be the subjective. On examinations, her weight is around 110 kg and the BMI is about 47 kg per meter squared. noted with the uncontrolled significance. Blood pressure is about 137/79, which is quite controlled, and A1C level about 9.2%, and fasting blood sugar around 10.9 millimole per liter. This is the current medications. So all the examinations and the current medication is the objective for the SOAP. How about the assessment? For the assessment, all the information that we obtain from the subjective and objective we conclude in the assessment. Firstly, we can find that this patient is severely obese because of the BMI 47 kg per meter squared. Besides that, this patient also has poor glycemic control due to HbA1c more than 7.5%, which is 9.2%. Besides, the FBS or fasting blood sugar is more than 8 millimole per liter. As we can see here, this patient received metformin 1 gram TDS only. So this metformin has already achieved the maximum dose and is a monotherapy drug. Even though the maximum dose, she can't achieve the HbA1c less than 6.5. Because of that, we need to consider dual therapy by add on some of these drugs in this class of agents. GLP-1RA and SGLT2 inhibitor are suggested because of this class of drug can improve the weight of these patients by losing the weight. We not encouraged to prescribe the sulfonylureas, meglitide, and also insulin because three class of the drug can increase the weight. We also suggest to this patient to do the weight management. So this is our plan. We suggest the dapagliflozin. So dapagliflozin is SGLT2 inhibitor. This drug can weight loss. Besides, this drug also can protect the renal and cardio. And we target this patient to have the HbA1c less than 7.5 in the next 3 months. Besides that, we need to advise her on physical activity, do some gardening, and take care on their nutritional plan. And we refer her to the obesity clinic and the MTEX. So let's move to the second case study. Mr. DK, 50 years old Indian man, has the diabetes about 5 years, and also the family history has the diabetes. So the family history can be the subjective. On examinations, his weight around 64.5 kg and the BMI about 22.5 kg per meter squared, and the HbA1c around 8.6%, and fasting blood sugar about 8.9 millimole per liter. And this is the list of current medication that he received for the treatment of diabetes. For the assessment, we can see that this patient has the poor glycemic control because the HbA1c and fasting blood sugar didn't achieve their targets. We can see that his current medication is a dual therapy oral antidiabetics, and this dose has not achieved the maximum dose as stated here. Because of that, even though the HbA1c and FBS didn't achieve the target, we didn't consider to add another agent of antidiabetics. We need to optimize the dose of these drugs. So we may increase the metformin 500 mg BD to 1 gram BD. And besides that, the glycazide dose also need to increase by 820 mg BD. We also encourage these patients to do the self-monitoring blood sugar, especially on the early morning before he taking his breakfast. And we need to refer this patient to the MTEC clinic. So let's move to this third case study. Here are the questions for your attendance, and kindly find it at Google Quiz form on the Google Classroom. So let's have a break. The second part of the lecture will talk about the acute complication of diabetes mellitus.